Let's start off with some rapid review. So when you see these things, you should automatically think about one condition. You see gout, intellectual disability, self-mutilating behavior in a boy. That would be Lesch-Nyhan syndrome. And that's an HGPRT deficiency and X-linked recessive. Now you see cysts invertis, chronic sinusitis, bronchiectasis, and infertility. This would be Cardinger's syndrome. It's a dynein arm defect affecting cilia. Alright, you see blue sclera. This would be osteogenesis imperfecta, which is a type 1 collagen defect. Now you see an upward and temporal lens dislocation, aortic dissection, hyperflexible joints, and pectus excavatum. This would be Marfan syndrome, and that's a fibrillin defect. And if you saw intellectual disability as well as these things, you'd think of homocystinuria. Now you see cafe-LA spots, precocious puberty, multiple endocrine abnormalities, and polystotic fibrous dysplasia. This would be McCune-Albright syndrome, and that's a G protein activating mutation. Now you see calf pseudohypertrophy, and a child uses arms to stand up from a squat, and it's a muscular dystrophy. This would be Duchenne's, and that's due to a severe X-linked recessive frameshift mutation in the dystrophin gene. And the child using the arms to stand up is Gower's sign. Now, what if you see slow progressive muscle weakness in boys? This would be Becker's muscular dystrophy. This is a non-frameshift deletion in dystrophin, and it's less severe than Duchenne's. You see an infant with cleft lip, palate, microcephaly, hollow prosencephaly, polydactyly, and cutis aplasia. This would be Patu syndrome, also known as trisomy 13. You see an infant with microcephaly, rocker-bottom feet, clenched hands, and structural heart defects. This would be Edwards syndrome, also known as trisomy 18. Now you see AML, cardiac defects, atlantoaxial instability, single palmar crease, and early onset Alzheimer's. These are all associated with Down syndrome, also known as trisomy 21. Here's an example of the blue sclera. You see an osteogenesis imperfecta, and this is the Gower sign that you typically see in Duchenne muscular dystrophy. Here's the pathophys behind each of the trisomies as well, trisomy 13, 18, and 21. And here is the pectus excavatum, the arachidactyly, and the dilation of the aorta that you see in Marfan's. Now let's talk about lysosomal storage disorders. So you have a patient with myalgias. They experience a second wind, cramps that improve after 10 minutes of activity. They also have myoglobinuria. This would be McArdle's disease, and it's a skeleton muscular glycogen phosphorylase deficiency. You have an infant with marked hypoglycemia, also found to have hepatomegaly. This would be Corey's disease, a debranching enzyme deficiency. You can also get von Gilkey's disease, and that's a glucose 6-phosphate deficiency, and this is more severe. Now you have an infant with hypertrophic cardiomyopathy. This is Pomp's disease because it affects the pump. And this is a lysosomal alpha-1,4-glucosidase deficiency. You have hepatosplenomegaly, pancytopenia, osteoporosis, avascular necrosis of the femoral head, and bone crises that look similar to leukemia. This is Gaucher's disease. All right, now you see this in a patient. Now in adults, this would mean a central retinal artery occlusion. But in peds, it's a cherry red spot on the macula. And let's say you see this, but the patient has no hepatomegaly. What would you be concerned for? This would be Tay-Sachs disease. And on histology, you would see an onion skin lysosome. Now let's say you have a cherry red spot on macula plus hepatomegaly. This would be Niemann-Pick disease, and that's due to sphingomyelin accumulation, and on histology you'd see foam cells, macrophages. Moving on to neonatal jaundice. So as you can see here, jaundice is yellow coloring of the skin and eyes, and you can see a healthy newborn versus a newborn with jaundice here. So you have a 5-day-old that has a bilirubin of 11. Their direct bilirubin is 0.5. Exam shows that they have jaundice. The parents say that he is eating and pooping normally. There's no red flag symptoms. What's the likely diagnosis? This is physiologic jaundice. And what do you want to do next? You would want to recheck bilirubin until levels peak and start to downtrend. And what's the pathophys of this? Newborns have reduced activity in their UGT enzyme, and so they have the inability to conjugate all the bilirubin. And this is usually self-limiting and transient. It's more common in preterm babies. Now let's say the total bilirubin continues to rise. What is the first treatment you want to try? This would be phototherapy. The levels continue to rise further. The level's now 30. What now? You want to do an exchange transfusion. And each exchange transfusion threshold is different based on the baby's characteristics. You can see a calculator here. You take all these different characteristics into account. Now you have a 5-day-old. They have a total bilirubin of 7. Their direct bilirubin is 0.5. They are fussy with signs of dehydration and concerns for not gaining weight. This would be concerning for breastfeeding jaundice, also known as lactation failure jaundice. And what's the pathophys of this? There's not enough intake of breast milk, therefore not enough stooling to remove bilirubin. And what's the clinical difference between a patient with breastfeeding jaundice versus a patient with breast milk jaundice? There's no signs of dehydration in a patient with breast milk jaundice. And what's the pathophys of breast milk jaundice? There's a high concentration of certain things in the breast milk that lead to impaired conjugation of bilirubin. It's not fully understood. Now you have a 5-day-old who has jaundice, failure to thrive, and cataracts. What's your diagnosis? This would be galactosemia. And what's the treatment for galactosemia? No lactose or galactose in the diet, because the issue with galactosemia is the inability to break down galactose, and both galactose, obviously, and lactose is a disaccharide sugar that contains galactose. You're going to want to eliminate those from the diet completely. You have a 4-week-old. They have jaundice ever since birth. Their total bilirubin is 9. Their direct bilirubin is 8. Exam shows hepatomegaly and increased transaminases and ALK Phos. What's your diagnosis? This would be biliary atresia. And what next steps would you want to get? You're going to want to get imaging and ultrasound, and then also liver biopsy, which is going to show inflammation of the bile duct. Now let's talk about immunodeficiencies. Generally, how do immunodeficiencies involving B cells present? They present as recurrent sinopulmonary infections and enteroviruses. And examples of this would be X-linked gamma globulinemia, aka Bruton's, or CVID. How does Bruton's and CVID differ clinically and diagnostically? Bruton's presents mainly in boys, and they have a complete deficiency in mature B cells. So you can remember this by the B's of Bruton's. You have Bruton's, B cells, boys, because it's X-linked. CVID presents later in life. Patients have normal B cell levels, but low levels of IgG, IgA, and IgM. And how do you treat both? IVIG. Now, how do T cell disorders present? Recurrent viral, bacterial, and fungal infections like Candida and PJP, and failure to thrive. And examples of this would be HIV, SCID, and DiGeorge. So a 6-month-old presents with an absent thymus, hypocalcemia, and a VSD, decreased T lymphocytes as well in labs. What's your diagnosis? This would be DiGeorge syndrome. What's the pathophys of DiGeorge? It's a 22q11 microdeletion. And clinically, how would it look? There's a mnemonic for this, and that would be catch-22. So C for cardiac defects, A for abnormal face, T for thymic hypoplasia, C for cleft lip/palate, and H for hypocalcemia, and then the 22 to remember the 22q11 microdeletion. Now we have a 7-month-old with gait ataxia, hypotonia, and spider angiomas, and IgA deficiency. What's your diagnosis? This would be ataxia telangiectasia. And is this a B cell or a T cell deficiency? Well, it's actually both. And you can remember this by the 4 A's of AT. So the ATM gene, ataxia, angiomas, and IgA deficiency of ataxia telangiectasia. Now we have a 1-year-old with recurrent otitis media, eczema, and CBC shows thrombocytopenia. What are we concerned for here? This would be Wiskott-Aldrich syndrome. And there's a mnemonic to remember these clinical findings. It's WATER. So WA for Wiskott-Aldrich, T for thrombocytopenia, E for eczema, and R for recurrent infections. And what's the pathophys? It's a defective WAS gene, leading to actinic cytoskelin impairment. Now we have a 6-month-old with thrush, failure to thrive, history of multiple episodes of gastroenteritis, absent tonsils, and a chest x-ray shows absent thymic shadow. What's your diagnosis? This would be SCID. And what's the definitive treatment in SCID? Bone marrow transplant. Now we have a 4-year-old with recurrent staph, Pseudomonas, Aspergillus infections. Exam shows lymphadenopathy. What's your diagnosis? Chronic granulomatous disease, also known as CGD. And the key thing with CGD is all the bugs that the patient is affected by are catalase positive organisms. And what's the pathophys of CGD? You have a deficiency in the NADPQ oxidase, impaired oxidative burst. Now you have a 6-month-old with recurrent infections, delayed cord separation, and poor wound healing, lacking pus at infection sites. What's the diagnosis? This would be leukocyte adhesion deficiency. And what would labs show? Labs would show leukocytosis, but neutrophils are absent at the site of infection. Now we have a 5-year-old with recurrent staph, strep infections, partial albinism, and neuropathy. What's your diagnosis? This is Chiari-Higashi syndrome. And what's the pathophys of this? You get defective lysosomal trafficking regulator genes. And what do you want to do in the next step of diagnosis? You're going to want to get a blood smear. And this would show giant cytoplasmic granules in granulocytes and platelets. And I should also mention, this is a microtubule defect, the LIS gene. Here's an example of what you would see on blood smear. And this is just a helpful table just to go over all the different immunodeficiencies and just how you would treat them. Now let's talk about infections. So you have a 14-year-old boy with sore throat, posterior cervical lymphadenopathy, and fever. What would you be concerned for? Mono. And what is typically done to confirm? The monospot is the most accessible. You can also use the heterophile test. Here's how the heterophile test works. A positive heterophile serum, you'd get clumping, and the test area would appear speckled, versus you'd get no clumping and a homogeneous solution if it's negative. And what's the most common pathogen in mono? Either the EBV or CMV virus. And this patient really wants to go back to playing contact sports. When can they? Usually you give it about 4 weeks from infection, as there's risk of rupturing the spleen with contact sports. Here's an example of a splenic rupture. You can see here that there's active contrast here indicating active bleeding. Now, a patient has a recent cold, 2-year-old, who presents with barking, cough, stridor, and hoarseness. What's your diagnosis? This would be croup, caused by the parainfluenza virus. And what would imaging findings show? They would show subglottic narrowing, also known as the steeple sign. And if it's mild croup, what do? You're going to want to do dexamethasone and supportive care. However, if it's more severe croup, like inspiratory stridor at rest, then you're going to want to hospitalize them and give them racemic epinephrine. Here's an example of that steeple sign from croup, that subglottic narrowing. All right. Now we have a 7-year-old who presents with sore throat, fever, tender cervical lymphadenopathy. What's your diagnosis? You also see the physical exam findings on the right. This would be group A strep pharyngitis. And what would next steps be? You're going to want to get a rapid strep test and a throat culture. And how would you treat this? Usually amoxicillin. Now, 2 days later, they refuse treatment. They now have a sandpaper-like rash, strawberry tongue, elevated anti-streptolysin O titers. What's our diagnosis here? This would be scarlet fever. And how do you treat scarlet fever? Oral penicillin B. Here's an example of that sandpaper rash. Now a patient has untreated sore throat for about 1 month, and they now have joint pain, fever, and subcutaneous nodules. This is acute rheumatic fever. And what's the pathophys of acute rheumatic fever? You get molecular mimicry, which leads to a type 2 hypersensitivity reaction. And there's a name for the diagnostic criteria. Do you guys know it? It's the Jones criteria. And the Jones criteria stands for, the J stands for joints, the O, shaped like a heart, stands for a heart because you get carditis and also valvulitis. N for nodules, the subcutaneous nodules here. E for erythema marginatum, and then S for Sydenham chorae. For if you get CNS involvement, you get these abnormal movements. And treatment of rheumatic fever, you're going to want to give them penicillin to eradicate the infection, and then you're actually going to want to continue giving penicillin afterwards as prophylaxis for progression of rheumatic fever to rheumatic heart disease. Now we have a 5-month-old who presents with coughing spells followed by an inspiratory gasp and sometimes vomiting. This is pertussis. And what's the next step in treatment? You're going to want to give azithromycin and get a PCR test to confirm the diagnosis. And what should close contacts get? Azithromycin prophylaxis within 21 days of exposure. So anytime you see post-tussive emesis on an exam or coughing until you vomit, be concerned for pertussis. Here's an example of that cough. Here's a figure showing the disease progression of pertussis. So you can see the symptom onset isn't necessarily when you were exposed to the disease, and you can spread the disease in that 3-week window in the catarrhal stage and the paroxysmal stage. Now we have a 10-year-old unvaccinated kid who presents with fever, headache, and swelling of the cheeks and jaw area for 5 days. What are we concerned for? Mumps. And how do you treat mumps? It's really supportive. And what are complications of mumps? The main one is orchitis because it can lead to infertility if it's bilateral. Here's an example of mumps. Now we have an 8-month-old who presents with recurrent history of nasal congestion and cough that has progressed to wheezing, rapid breathing, and retractions. Chest x-ray shows peribronchial thickening. What are we concerned for? This would be RSV bronchiolitis. And how do you treat this? Supportive, but if they're severely dehydrated, you're going to want to admit them for fluids. And what are some complications? There's increased risk for apnea in very young infants, and there's also an increased risk of asthma. Here's an example of what RSV would look like. You can see bronchiovascular prominence, but there's no consolidation or anything like that. Now we have a 4-year-old who presents with sudden onset fever, sore throat, drooling, a muffled voice, and difficulty breathing. They're sitting upright and leaning forward. What's the next step? You're going to want to do ABCs, assess their airway, intubate if they're still in distress. And so what if they see this on x-ray? What's that called? That's called the thumb sign. And what's the most common organism for this? It's usually H-flu, and this is called epiglottitis. Now let's talk about some rashes. You have a 5-year-old who presents with symmetrical finger joint pain, fever, and a rash which started on their cheeks. They now have a lace-like rash on their arms and trunk. What's the diagnosis? Fifth disease. And what's the most common pathogen? Parvo B19. Treatment is supportive, often with NSAIDs, and it's often associated with arthralgias. And as a torch, it's associated with hydrops fetalis. It can also cause aplastic crises because it targets RBC progenitors. Here's an example of that rash. Now we have a 3-year-old who presents with fever, sore throat, decreased appetite, followed by the appearance of small red vesicles on the palms, soles, and inside the mouth. What are we concerned for? This is hand, foot, and mouth disease. And what's it caused by? What bug? Coxsackie A. This is different than Coxsackie B, which causes pericarditis. And they're both part of the enterovirus family. So now we have a 4-year-old who presents with high fever, cough, runny nose, conjunctivitis, followed by a morbilliform rash that started on the face and spread downwards. They also have small white spots on the buccal mucosa. They're unvaccinated. These spots on the buccal mucosa are also known as Koplik spots, and this is measles. So you get Koplik, cough, chorea, and conjunctivitis clinically. And late complications, you can get subacute sclerosing panencephalitis, and that presents 7 to 10 years following infection and is often fatal. Now we have a 5-year-old who presents with 4 days of fever, cold symptoms, swollen lymph nodes behind the ears, and a morbilliform rash that started today on the face and spread downwards to the rest of the body. You also see these findings on the right here. They're called Forchheimer spots. And this would be rubella. You can present with those Forchheimer spots. And how does congenital rubella present? You get those sensorineural hearing loss, cataract, and cardiac defects. And we're going to talk about that in our next section, torch infections. So when is rubella infection the most common in pregnancy? First trimester. And how does congenital rubella syndrome present? We already kind of talked about this. Sensorineural deafness, cataracts is the biggest thing. You can also get a rash and microcephaly. And how do you prevent this? Vaccination before pregnancy, but not given during. And you also want to screen for rubella in the mom. So there's a mnemonic for this. It's I heart ruby earrings. I for eye, cataracts. H for heart, for the heart issues, usually a PDA. R for ruby, for rubella. And E for earrings, for the sensorineural deafness. All right. So now I have a neonate with chorioretinitis, diffuse intracranial calcifications, and hydrocephalus on MRI. What's the diagnosis? Toxoplasmosis. And how do you treat for the newborn? You give them this combination of medications. And how do you prevent toxo during pregnancy? You want mom to avoid raw meat, shellfish, cats, and wash fruits and veggies. In treatment for mom, you give spiromycin to prevent fetal transmission, but often most maternal infections are asymptomatic. Sometimes you can see B symptoms though. Now we have a neonate that presents with hypertrophic scars, cataracts, limb hypoplasia, microcephaly, and chorioretinitis. What's the diagnosis? This would be VZV. And how do you treat VZV? Acyclovir. And how does congenital CMV syndrome present? Most importantly, no cataracts. So you can see this is kind of similar to rubella, but the most important distinguishing factor would be the no cataracts in CMV syndrome. Additionally, you have the periventricular calcifications. I always get these mixed up, so remember, CMV, no cataracts. Rubella, yes cataracts. So we have a neonate who presents with vesicular skin lesions, seizures, lethargy, and jaundice. What are we concerned for? HSV. And how do you treat HSV? Acyclovir or valcyclovir. And how is genital HSV transmitted at birth? Kind of already said it, but via genital tract lesions, it's not transplacental. And what do we do if the mom has known HSV? You're going to want to give mom acyclovir beginning at 36 weeks and continue until labor. And then you're going to want to do a C-section if there's active genital lesions or prodromal symptoms like vulvar burning or pain. Now we have a neonate that presents with jaundice, hepatosplenomegaly, rash, nasal discharge, and periosteitis. On radiographs, they also have a morbilliform rash on their hands and soles. This would be syphilis, early syphilis. And how do you treat this? 10 days of penicillin. And so let's say they go untreated, how would late congenital syphilis present? This is uncommon to see in common practice, but you get Hutchinson teeth, saddle nose deformity, frontal bossing, and interstitial keratitis, and hearing loss. Typically by 2 years of age. How does primary and secondary syphilis present? So primary would be that painless chancre, and secondary would be that morbilliform rash, condyloma lata, and patchy alopecia. How do you screen for syphilis in the mom? Usually you do a universal first trimester screen. And like we said before, the only treatment is penicillin. So if there's an allergy to penicillin, you undergo desensitization. And what's a complication of treatment of syphilis? You get the Jarisch-Herxheimer reaction. So you get B symptoms, tachycardia, tachypnea, and hypotension from lysis of all those syphilis. Now let's talk about genetic disorders. So we have a newborn with hypotonia, flat facial profile, upslanting palpebral fissures, epicanthal folds, an ASD single palmar crease, and a gap between the first and second toes. These are all things that are associated with Down syndrome, trisomy 21. What's the biggest risk factor? Advanced maternal age. And there are some high-yield GI organ conditions associated with Down syndrome. I listed 3. There's Hirschsprung's disease, duodenal atresia, and annular pancreas. Now we have a newborn with low-set ears, clenched fists with overlapping fingers, rocker bottom feet. Cardiac exam reveals VSD. What are we concerned for? This would be Edwards syndrome, or trisomy 18. Now we have a newborn with microophthalmia, cleft lip and palate, rocker bottom feet, polydactyly, and VSD, also missing areas of the skin on the scalp. We'd be concerned for PA2 or trisomy 13 syndrome. And here's an example of the different serum markers you can see in pregnancy that are concerning for each of the trisomies. The biggest one I would say we'd be tested on is the beta HCG in trisomy 21. Now we have a 15-year-old girl with short stature, coarctation of the aorta, webbed neck, short fourth fingers bilaterally, and widely spaced nipples. They come in for concern of lack of menses. This would be Turner syndrome. And what's the pathophys of Turner syndrome? It's that X45 phenotype. And what's the pathophys of the amenorrhea in Turner's? You have streak ovaries, which cause primary ovarian insufficiency, so you have decreased estrogen, decreased androgen, and in response, increased FSH and LH. We have a 5-year-old with broad forehead, full cheeks, a wide mouth with spaced teeth. They're highly sociable and sensitive to loud sounds. They also have aortic stenosis, and labs show hypercalcemia. Here we'd be concerned for Williams syndrome. And what's the pathophys of Williams syndrome? Deletion at chromosome 7. Now we have a newborn with low birth weight, microgenia, microcephaly, single palmar crease, widely spaced eyes, broad nasal bridge, downward slanting palpebral fissures, and a high-pitched cat-like cry. Echo shows VSD. Here we'd be concerned for the Cri-du-Chat. We have a 16-year-old tall adolescent with long limbs, joint hypermobility, history of frequent joint dislocations. Physical exam reveals pectus excavatum, scoliosis, and superior lens subluxation with normal intelligence. We went over this earlier in the video. This is Marfan syndrome. And what's the most common cause of death in Marfan's? Cardiac complication from aortic aneurysms and aortic dissections. And now, We also went over this earlier, but you have the same patient, but now you have a downward lens subluxation and intellectual disability. This would be homocystinuria. Now we have a 15-year-old female with hyperextensible skin, joint hypermobility, and easy bleeding, their normal height and weight for their age. This would be hypermobile EDS, or Ehlers-Danlos syndrome. Now we have a 2-year-old with developmental delay, minimal speech, frequent laughter, and a happy demeanor. Physical exam reveals ataxic gait, microcephaly, wide mouth, strabismus, and spaced teeth. This would be Angelman syndrome. And what's the pathophys of Angelman's? You have microdeletion at chromosome 15 on the maternal copy. Now you have a 3-year-old with hypotonia, developmental delay. They like to eat. Early signs of obesity. Physical exam shows almond-shaped eyes, small hands, and feet. This would be Prader-Willi syndrome. And what's the pathophys of this? This is microdeletion on chromosome 15 of the paternal copy. Now we have a 6-month-old with a weak cry, difficulty swallowing, minimal limb movement, and a floppy appearance. Physical exam reveals absent deep tendon reflexes and tongue fasciculations. What's your diagnosis? This is spinal muscular atrophy, or SMA. And what's the pathophys of SMA? You have degeneration of lower motor neurons at the anterior horn. Now we have a 4-year-old with history of multiple fractures after minor trauma, blue sclera, short stature. Physical exam reveals joint laxity and bowing of the limbs. Dental exam reveals brittle teeth. Doesn't matter what I say. If you see blue sclera, it's osteogenesis imperfecta. Now let's talk about some pulmonology. We have a premature neonate with rapid breathing, nasal flaring, grunting, intercostal retraction shortly after birth. Chest exam reveals ground glass opacities with air bronchograms. What's your diagnosis? This would be NRDS. And what's the pathophys of NRDS? Surfactant deficiency. And how do you prevent this? You give corticosteroids for lung maturation. Here you can see someone with NRDS. You almost see complete opacification of both lungs from those ground glass opacities. And what are next steps if you suspect NRDS? You're going to want to do CPAP, and if that doesn't work, intubation with artificial surfactant. Now we have a newborn with tachypnea, mild retractions, and nasal flaring within the first few hours after cesarean delivery. Chest x-ray shows prominent pulmonary vascular markings and fluid in the fissures. This is transient tachypnea of the newborn. And what's the pathophys of this? You have a delay in resorption and clearing of fluid from the lungs. And how do you treat this? Supportive care. This is associated with macrosomia and C-sections. Think of vaginal birth as wringing out all the fluid. So if you don't have that, like in a C-section, then you have transient tachypnea of the newborn. Now we have a premature infant born at 28 weeks gestation on day of life 2. They have intermittent episodes of apnea, bradycardia, and desaturation starting on day 2 of life. Episodes often resolve with stimulation. This would be apnea of prematurity. And what's the pathophys of this? Immature control of the respiratory function, and treatment is supportive. Now we have a term newborn with cyanosis and respiratory distress shortly after birth. They're unresponsive to supplemental oxygen. Amniotic fluid is noted to be green. Echo shows significant right to left shunting at the ductus arteriosus. This would be persistent pulmonary hypertension of the newborn. And what's this secondary to? Mentioned it with the green amniotic fluid. This would be meconium aspiration syndrome. And on chest x-ray, what would you see? You would see asymmetric patchy infiltrates. Now we have a 2-year-old who develops cough, wheezing, and difficulty breathing. Physical exam reveals decreased breath sounds on the right side and inspiratory stridor. What's the diagnosis? Oh, it's foreign body aspiration. And what are next steps? You're going to want to assess ABCs, avoid positive pressure ventilation, and if they're stable, bronchoscopy for removal. Here's an example of what you'd see on a foreign body aspiration. So you see increased translucency on the right, which favors air trapping versus the left. This was actually a case of a ground nut found in the right bronchus. So now we have a newborn with severe respiratory distress and cyanosis shortly after birth with a scaphoid abdomen and decreased breath sounds on the left side. What do we want to do next? Ultrasound or X-ray? So let's say a chest X-ray reveals bowel loops in the thoracic cavity. What would this be concerning for? This would be concerning for congenital diaphragmatic hernia. Here's an example of one. It's hard to see, but you can kind of see loops of bowel here and then here. Now let's talk about peds GI. So we have a 9-month-old with sudden onset episodic severe abdominal pain and inconsolable crying. Parents report vomiting and a recent passage of bloody mucoid stools. Physical exam reveals a palpable sausage-shaped mass in the right upper quadrant. What's the diagnosis? This would be intussusception. And what are the next steps if the patient is still fussy? You're going to want to get an ultrasound, and that would show target sign. And how do you treat this? If there still is an intussusception, you're going to want to do NG nasal decompression and an air enema. And here's those current jelly stools, or that bloody mucoid stool, and this is what it looks like. Now we have a premature infant on day of life 10 on enteral feeds with abdominal distension, feeding intolerance, and bloody stool. Their vital signs reveal a temperature of 35 degrees Celsius. What are we concerned for? This would be concerning for necrotizing enterocolitis. And what's the X-ray findings you would see? You'd see pneumatosis intestinalis, so air in the intestine wall. And what would next steps be? You're going to want to stop enteral feeds and do an NG decompression and antibiotics. Here's an example of pneumatosis intestinalis. You can see there's dark streaks of air that kind of follow the colon wall. This would be concerning for necrotizing enterocolitis. All right. Now we have a 4-year-old who presents with history of passing hard and frequent stools with intermittent diarrhea as well. Physical exam reveals abdominal distension with a palpable stool in the left lower quadrant, and a rectal exam shows firm stool. What are we concerned for? This would be functional constipation. And what's the number one pharmacotherapy? Polyethylene glycol. And you don't want to give fiber to these patients. Now we have a 2-month-old breastfed infant that has frequent loose stools containing blood and mucus, no vomiting or fever, but fussiness after feeds. Physical exam is unremarkable with normal growth patterns. What are we concerned for here? This would be concerning for food protein-induced allergic proctocolitis. And the pathophys of this, what is it? It's non-IgE mediated food allergy. And how do you treat this? Eliminate all of dairy products from mom's diet. And then you could also do hydrolyzed formula if the baby's formula fed. Now we have a newborn with failure to pass meconium within the first 48 hours of life, abdominal distension, and bilious vomiting. X-rays show small, dilated bowel loops. What are the next steps? You're going to want to do a contrast enema. And this shows microcolon. What are we concerned for? A meconium ileus. And the most common cause of meconium ileus is what? Underlying disease. Cystic fibrosis. Here's an example of a meconium ileus. You can see dilated small loops of bowel. This is a contrast enema, so you can see microcolon, meaning the colon's smaller than normal. Additionally, these represent the meconium. Now we have a newborn with failure to pass meconium within the first 48 hours of life, abdominal distension, bilious vomiting, and a DRE reveals large expulsion of stool. There's a tight anal sphincter. What are we concerned for? This would be concerning for Hirschsprung's disease, and the large expulsion of stool is known as the squirt sign. What X-ray findings would you see? You'd see decreased air in the rectum. And what's the next steps in diagnosis? Suction rectal biopsy. Here's an example of Hirschsprung's disease. So since you get the absence of the ganglion cells of the distal colon and rectum, due to the failure of the neurocrest cells to migrate. You don't see any air here. Now we have a newborn with trisomy 21, has bilious vomiting and no passage of meconium within the first 24 hours of life. History of polyhydramnios. Physical exam reveals a distended abdomen. X-ray shows a double bubble sign. What's the diagnosis? This would be duodenal atresia. And instead, if it showed a triple bubble sign, that would be jejunal atresia. Here's an example of the two. 1, 2, double bubble. 1, 2, 3, triple bubble. Now we have a 2-week-old infant with sudden onset bilious vomiting, severe abdominal pain and lethargy. Physical exam reveals distended tender abdomen. Upper GI series shows a corkscrew appearance of the duodenum. What are we concerned for? This would be concerning for a midgut volvulus. And what's the risk factors for this? Malrotation. And what are next steps? You're going to want to do an upper GI series, like we already kind of did in this case vignette. Here's an example of what a midgut volvulus due to malrotation would be. Now we have a 3-year-old with painless rectal bleeding, passing dark red stools intermittently over the past few days. Physical exam is unremarkable with no abdominal tenderness. What are the best next steps? You're going to want to do an X-ray and then also a technetium scan. And the technetium scan comes back positive. What is the diagnosis? This would be a Meckel's diverticulum. And what's the pathophys of Meckel's diverticulum? There's a patent remnant of the omphalomesenteric duct. Now we have a 3-month-old with frequent effortless regurgitation after feeding, but remains generally content. They're feeding well and growing normally. Parents do note occasional spit-ups without distress. So this would be esophageal reflux, so gastroesophageal reflux, not GERD. And what would treatments be? Maintain infant in upright position for 20 to 30 minutes after feeds. Now in contrast, we have a 4-month-old with regurgitations after feeding, irritability, arching of the back, poor weight gain. They also cough and choke during feeds. Now this would be concerning for GERD. And how do you treat this? Similarly, you do positioning therapy, but you can also do food thickeners, avoidance of secondhand smoke, and then you can do PPIs if it's severe. Now we have a 5-week-old infant with progressively worsening non-bilious projectile vomiting after feeds, followed by persistent hunger. Physical exam reveals a palpable olive-like mass in the right upper quadrant. What's the diagnosis? This would be pyloric stenosis. And what's the best next step? Ultrasound would show a thickened pyloric muscle. And what's the definitive treatment? A myotomy. Now, a newborn has midline abdominal wall defect covered by membranous sac containing intestines, along with hypotonia and a single palmar crease. Genetic testing confirms trisomy 21. What's the diagnosis? So this would be omphalocele. It's associated with trisomies, and then also Beckwith-Wiedemann syndrome. And what are the next steps? Wrap the sac with wet dressing and plastic wrap, surgery within 24 hours. And what's the pathophys of an omphalocele? You have impaired closure of umbilical folds in utero, causing persistent herniation of midgut derivatives. Now we have a newborn with an abdominal wall defect to the right of the umbilicus, exposing erythematous bowel loops without a covering membrane. What's the diagnosis? This would be gastroschisis. And what's the pathophys of gastroschisis? You have too small of a peritoneal cavity, so bowel ruptures at the weakest point in the anterior abdominal wall. And how do you treat this? Same as omphalocele. Here's an example of the difference between the two. So the gastroschisis, you can see it's lateral to the midline versus omphalocele, it is midline.